Welcome everyone to our webinar this afternoon. We are joined today by Dr. Rob Weinkove, Haematologist and Clinical Director of the Malaghan Institute of Research, and he will talk to us today about the COVID vaccine and haematology. If you have any questions, please put them in the question box at the bottom where you can see the toolbar. Otherwise, you can text them through the chat and Rob will be able to see them and answer them during his presentation. Over to you, Rob.
Yeah, thanks very much, and thanks for the introduction. So, as you heard, I'm a clinical director at the Malaghan Institute, and I also am a clinical haematologist, and I have an interest in immunology and supportive care through some of our work. So it's been really, really important to work out what we can do for patients in relation to the COVID vaccine. So this is a bit of an update. I have given a couple of talks before, you might have seen. So just by way of background, this virus, this coronavirus, is one of a number of coronaviruses. In fact, you've all had various types of coronaviruses before in your lives. But the SARS-CoV-2, the coronavirus that causes COVID-19 disease, can make people particularly sick. And it's particularly important for patients with blood cancers, because we know that compared to people without blood cancers, people who have blood cancers are at higher risk of getting really sick with COVID-19 and sadly at higher risk of dying in studies that have been conducted before. And this has happened in a number of places around the world. We're hopeful that we're getting better at treating COVID-19 when it does happen now. We've got a number of treatments like steroids and tocilizumab that we know can improve outcomes. Our intensive care doctors are better at using ventilation strategies. And of course, by avoiding having COVID here at all, we can avoid our intensive care units and our hospitals becoming overwhelmed, as happened in some countries. But nonetheless, this is still a virus that you, those of you who have blood cancers or have loved ones who have blood cancers, really want to avoid getting. And while we've been in a really privileged position in New Zealand not to have to face this in a widespread way, it's only a matter of time really before this virus comes to our shores once borders reopen. And so it's really important that we have protection. And that protection, like for many viruses, usually comes through something that's called herd immunity. And what herd immunity means is not that every single person in a community is immune to a virus or an infection, but that enough people are immune to it that you can't get those chains of transmission that lead to enormous outbreaks. So even if it does come, it can't go on to spread from person to person and grow exponentially, get higher and higher in its level. Therefore, everybody gets infected. So herd immunity is really critical for viruses like this. And herd immunity and what's needed for herd immunity varies depending on how transmissible a virus is. And COVID-19 appears to be very transmissible, and it's probably become more transmissible as it's evolved over the last year that it's been around. It's more transmissible than influenza, but a bit less so than measles. But it does mean that in order to get herd immunity in this country, as in any country, we're going to need 80 or 90% of the population to be vaccinated against this virus to help stop people who are very vulnerable to the virus, who aren't going to respond as well to vaccines, to help prevent them from getting really sick at it. And so really the government's message here, and I strongly endorse that, is it's everybody's duty to get vaccinated against COVID-19. And I strongly endorse that at every point. So I want to talk about the COVID vaccine. So the government's announced that the COVID vaccine that's going to be rolled out, at least initially, is the Pfizer vaccine. And the Pfizer vaccine is one of a couple of something called RNA vaccines. And these are relatively new type of vaccines that have been proven now in trials conducted starting over a year ago, and now with many, many tens of thousands of people and millions since vaccinated, have proven to be the real surprise in terms of vaccines, in terms of how effective and safe they are. And I want to just briefly explain that, because some people are a bit scared of the idea that this is an RNA vaccine, there's genetic code. And I think to put that into perspective, what I want to point out is what a virus is. So a virus is not a cell, it's not a bacteria, it's not a worm or anything like that. A virus is a very, very tiny thing that you can only see with a special kind of electron microscope. You can't see it with the naked eye, you can't even see it looking down the microscope as we do in the hematology department every day. A virus is basically a little tiny package, an envelope of fat, a lipid, what we call lipid, and inside that lipid is some genetic code. That's what a virus is. So the coronavirus is a package of fat with a bunch of genetic code. Now the virus itself, the coronavirus itself, is that, And it actually contains in it and encoded in it about 29 different proteins. We don't know what all of them do. Some of them might not do anything, but there are certainly 5 major proteins that are encoded and have an important function in that virus. So that's what a virus is. The Pfizer vaccine is a synthetic version of that. That is a synthetic fatty vesicle, a synthetic lipid layer with only the code for one of those proteins. So it doesn't have all the other 28 proteins encoded. It doesn't have all the nasty proteins on the surface. It doesn't have the proteins that allow it to make more copies of itself. It's completely synthetic. It's unable to replicate like the coronavirus does. It can't get into the tissues of your lungs and cause disease. It's not an active virus. It's only got the essential parts that you need to be able to make an immune response against it. And that's what that Pfizer vaccine is. And there's another company making another one called Moderna that's been very widely distributed in the United States. And there's huge numbers of people, many millions of people. In the UK alone, they've vaccinated over 11 million people, specifically with the Pfizer vaccine. So it's got a huge and fantastic safety record. So is this safe for patients with blood cancer? Yes. Now, some of you might have been told that there's certain types of vaccines that you need to avoid. The types of vaccines you need to avoid if you've had certain types of immune suppression are so-called live vaccines. And that's because there's a handful of vaccines, mainly older ones, that actually contain a live virus. The Pfizer COVID vaccine, the one that's been rolled out in New Zealand, is not live. So even if you've been told to avoid live vaccines like yellow fever or the shingles vaccine, you can have the Pfizer coronavirus, and you should have the Pfizer coronavirus unless you're known to be allergic to a component of it. It does not have a risk of causing thrombosis, so the rates of thrombosis or clots are the same in people who've had the Pfizer vaccine compared to those who haven't. There is a particular rare syndrome that can happen after one of the other coronavirus vaccines, but not the one that's currently been rolled out in New Zealand. And then there are very rare events like provoking low platelet counts or ITP that can happen with the Pfizer vaccine. It's very rare. In the UK experience, it's about 1 in 100,000. And even people, in my practice, even people with a history of ITP, we are advising them to get the Pfizer COVID-19 vaccine because that rate of low platelets is so low. In fact, it's likely to be much, much lower than the rate of getting low platelets from the actual infection itself. What's wonderful about the Pfizer vaccine and many of the other types is how singularly effective it is. So in the trials, we're looking at 90 to 95% effective at preventing even asymptomatic infection, so even infections that cause no symptoms, and 95 to 100% effective at preventing really severe coronavirus disease. Now, this is mainly among healthy people, but similar things have happened in Israel where they've rolled out the Pfizer COVID vaccine to more than half of the population now, and they've seen incredible rates, really one of the most effective vaccines out there. So it's very, very effective in healthy people, and really I think is going to be key to achieving the herd immunity that people with a compromised immune system are going to require. And that brings me on to how effective this is going to be in people with blood cancers. And that is where there's a variety of answers. So because a number of countries around the world are further in their vaccine programs than New Zealand is, particularly, for example, the UK, Israel, some parts of the United States, although it's pretty patchy there, we're beginning to see reports come from haematology organizations in those countries where they've looked at specific groups of patients with specific types of blood cancer and to some extent taking specific kinds of treatment. And we're getting some feeling for who is going to be well protected by the vaccine and who might not be so well protected by the vaccine. So first, the good news is that, for example, people with chronic myeloid leukemia and probably with other myeloproliferative disorders do appear to develop a strong antibody response to the vaccine. These are relatively small series so far, but from what we see, the responses to the vaccine in people with CML who are on drugs like imatinib and dasatinib and nilotinib seem to be broadly similar to healthy individuals. And we think it's likely to be similar for people with other myeloproliferative neoplasms as well. Then there's people with myeloma. Some of you may have myeloma. We are seeing, there's a big paper in the Lancet that looked at COVID-19 vaccine responses in people with myeloma. They were only looked at this point after the first dose, and they did see slightly reduced vaccine responses in people with myeloma. Nonetheless, about 50 to 60% of people had a good level of protective antibody after just one dose. And we expect that to be higher after people get the full 2-dose course. So that's reasonably good outcomes. I would note that people who are actively on the cytotoxic chemotherapies like big doses of cyclophosphamide or really big doses of steroid are likely to respond a bit less well. And then I guess the less good news is that for people who are on medicines that actively deplete B cells, the vaccine responses are likely to be less robust. And by that, I mean that a lot of the blood cancers that we treat are cancers of the B cells, and the B cells, the B lymphocytes in our body, are the cells that go on to make antibodies. And so people with, for example, CLL who are taking drugs like ibrutinib or venetoclax or zanubrutinib, or people who've recently received drugs like rituximab or obinutuzumab for B-cell lymphomas, we do know that those drugs specifically knock out the cells that can make antibodies. So it's not surprising that some of the studies so far have shown that people who are currently taking those medicines, or for rituximab or obinutuzumab, have had them over the past 6 to 12 months, have a diminished response to vaccination. Now, just to point out that mostly what we're measuring here is antibody responses to vaccines. And the antibodies are not the only part of your immune system that responds to vaccines. They're the one that's easiest to measure. So we measure that most often. So even if you are currently taking a B-cell depleting treatment for your chronic lymphocytic leukemia, or you've recently come off chemotherapy with rituximab or obinutuzumab for B-cell lymphoma, you may still respond to the vaccine. You may still get some protection. So personally, I'd still be recommending that you go ahead and receive the vaccine. It's just that you may go on to need boosters later on, and we can't guarantee that you'll be fully protected. So that's important to know. Now, some of you might have recently had more intensive chemotherapy, like acute leukemia chemotherapy. Interestingly, people with low neutrophils who've recently had chemo can respond to vaccines. It's probably a diminished response, but we tend to recommend going ahead with treatment, usually when the neutropenia is resolved. For people who've had bone marrow transplants, what we're doing in our own centre is saying to go ahead with COVID vaccines 3 months after your transplant, whether that's an autograft or an allograft. The one exception might be people who are still actively on immune suppression following their allograft. We suspect if you're still taking cyclosporin or tacrolimus later on, because say you've had bad graft versus host disease, your response to the vaccine may be diminished. You probably, if that's the case, you're probably actually already under a transplant team, and you probably have a transplant nurse specialist you can contact for advice. We are generally saying, actually, may as well still go ahead and get the vaccine, because some protection is better than none. For many patients with blood cancers, your protection may not be complete, and therefore we're still likely to advise that you retain some of those precautions, like watching out, wearing a mask when you're in public spaces, or at least in very close proximity to people, particularly in public transport. And I'm not quite sure, none of us are quite sure at the moment, what we're going to be advising people with blood cancers who've been vaccinated regarding overseas travel. In practice, it's very, very difficult at the moment anyway, and the tricky situation is going to arise later in the year as those borders open up and it becomes more feasible to people to travel internationally. I wouldn't be too worried about Australia, where COVID rates are very low, and where if you were unlucky enough to get sick with COVID, you'd be eligible, if you're a New Zealand resident, to publicly funded healthcare. But the problem with going somewhere like the US or Europe is it'll be very hard to find travel insurance that will cover for COVID disease. And if you did get sick overseas, the costs of, if you got very sick, could be very high. So that is one issue that we don't have an answer for yet. I think what will happen is by the time we get to the stage that the borders are opening more widely, we'll have a lot more information about how people are likely to respond to COVID vaccines and who's likely to be protected. It's very, very important. I would just point out there was one study recently in the Lancet from the UK experience that emphasized the importance of people with blood cancers getting both doses of the vaccine. So the Pfizer coronavirus vaccine is meant to be given as 2 doses 3 weeks apart. We strongly recommend that you get both doses for optimal protection. There is a degree of protection from the first dose, but particularly for people with suppressed immune system, that second dose may be very important. And in fact, it's quite likely that some patients with blood cancers may need boosters later on, as indeed we may all require. So I'm just going to run through a couple. There's one question on the list, and then I was going to run through some questions that we've had commonly and just see if it answers some of your questions. And then perhaps just point out to you that we can take additional questions as you come up with them. So Trish is asking, what's the problem with the shingles vaccine when you have lymphoma? So the shingles vaccine that's currently being offered to be purchased in New Zealand actually is what's called a live attenuated virus. So instead of making a synthetic protein or a synthetic package, the shingles vaccine that's currently offered here, which is called Zostavax, is actually a type of virus that has been modified so it's less infective. Now, the problem with that is if you've had certain types of immune suppression treatment, and specifically it's drugs like bendamustine, fludarabine, if you've had a history of Hodgkin lymphoma in your lifetime, or if you've ever had an allogeneic bone marrow transplant, among people who've had those types of treatment or have those disorders, they can actually get sick as a result of the shingles vaccine itself. So even though it's an attenuated virus, it can actually spread. And there's been case reports of people, for example, with CLL who have got that type of shingles vaccine, where it's actually caused a form of shingles, and it can be quite severe. So if you're in that group, we don't recommend the shingles vaccine. There is a new shingles vaccine that's licensed in the United States, but it's not yet been registered in this country, and it's certainly not funded here, that would be safe to give to those people, but we don't have it yet. So for people who've had those drugs or who've been advised not to receive the current shingles vaccine, it's a matter of watching out for shingles and seeing a doctor straight away if you think you might be developing it, and getting straight on antivirals. Chris asks, will there need to be a yearly top-up like the flu jab? Quite possibly, maybe probably. So we've seen the SARS-CoV-2, which is the virus that causes COVID-19 disease, mutate, and we've seen it mutate, not because that's unusual. Every respiratory virus out there is mutating. It's just this one is being watched so closely. And we've seen mutations happen, and unsurprisingly, some of these mutations are making it more transmissible, and some of the mutations might make it resistant to some of the vaccines that are out there. Fortunately, the Pfizer COVID vaccine has shown good effectiveness against some of the nastiest variants that have come out so far, including the UK variant and the South African variant recently. And there does appear to be some effectiveness against the Brazilian variant. Nonetheless, all the companies that are making COVID-19 vaccines, or at least all the major ones, are starting to make tweaked versions of their vaccine to cover those variants even better. So it's quite likely that there will be booster jabs. The UK, for example, is already planning to administer booster jabs to the entire population later on during 2021. And it's possible that we might need to have yearly boosters to cover the variants as they emerge. So yes, it's quite likely. And just to point out, even though herd immunity can be attained against this virus through these vaccines, we won't eradicate this virus from the face of the earth. It will still be here in 5 or 10 years' time. And the reason is that this particular virus can also be carried by various animals. It's been shown that cats, mice, rats can all harbor certain variants of this coronavirus. So even if you vaccinated every human on Earth, it can still be carried by certain animals, including domestic animals. So I don't think it's going to disappear, and I think we'll still be tackling this for a long time to come. Fortunately, I don't think as long as we get good vaccination take-up, we won't be facing the kind of pandemics or disasters that we've seen in some countries overseas. I've got a question here about getting the coronavirus or COVID-19 vaccine before the flu vaccine. So it depends at what point you can get them. We recommend for most of our patients that you have both. And what you're meant to do is have at least 2 weeks between a dose of the flu vaccine and a dose of the COVID-19 vaccine. Personally, I'm recommending for my patients that they prioritize the COVID-19 vaccine, but not all hematologists agree with that. What I do is look at what you're offered. So if you're offered the flu vaccine right now and you haven't received an invite for the COVID-19 vaccine yet, go ahead and get your flu vaccine and then just wait 2 weeks before your first COVID-19 vaccine dose. What I would suggest, again, for hematology oncology patients, so patients with blood cancers, this 3-week interval we're not entirely sure, but this 3-week interval might be quite important. So if you've got the first COVID-19 vaccine dose, I wouldn't delay your second one in order to try and fit a flu vaccine jab in the middle. I'd get your first and your second, and then wait 2 weeks after the second and get the flu vaccine after that. MedSafe is saying not only does the vaccine have provisional authorization, but they don't know the long-term effects. So it was initially granted emergency authorization. It's now been granted full authorization by the FDA in the United States. MedSafe will be giving it full authorization, I'm sure, in the near future. It's true that with the vaccine that's come up recently, you can't know every long-term effect. However, from what they've seen so far, this looks incredibly promising. What I can guarantee you is that COVID disease has a number of very profound, very, very common and very serious long-term effects. So as well as the fact that about 1 in 100 people or just over who get COVID-19 infections die as a result, and that goes up with age, up to over 10% when you're getting in very elderly people, and is as high as can in some series in blood cancer patients, as high as 30% of people in some countries have died from COVID-19. But as well as those high death rates, about a third of people who get coronavirus, even mild forms, get this thing called long COVID with ongoing symptoms of shortness of breath. You've seen the information about that. So I personally have recently had the Pfizer vaccine. I wouldn't hesitate to recommend everybody get it. And based on what I've seen so far, I'm not worried about long-term effects. A question about having CLL from Simon and having one round of chemo 4 years ago, heading for another round. So should I get the vaccine before chemo? That's a really, really good question. So if lymphodepleting chemotherapy, such as that we use for CLL, is not urgent and the coronavirus vaccine is imminently available, I have on a couple of occasions deferred treatment by a month or two to let people get vaccinated. The thing is, you have to wait a little while. So remember, there's 2 jabs, there's 2 doses of the COVID-19 vaccine, 3 weeks apart. And then really before you give drugs like rituximab or intensive or lymphodepleting chemotherapy, you want to wait at least 2 weeks after the second jab. So even if you got the first dose of the coronavirus vaccine tomorrow, it would be 5 weeks before ideally it'd be 5 weeks before starting chemotherapy. So that's really a discussion that you have to have with your own clinician who's planning the chemotherapy as to whether it's safe to wait. If it's not safe to wait, the treatment of the cancer takes priority. The COVID vaccines can be caught up later. So if it's urgent, absolutely must go ahead with treatment. Occasionally in CLL, there's a bit of leeway. It really depends, and that's something that only a clinician who knows your case could advise on for you. It's a very personal thing. Suppressed immune disorder, currently pregnant, should they wait until after birth of the baby before having this vaccine? Well, that's a good question. So the coronavirus vaccine, the Pfizer coronavirus vaccine, appears to be safe in pregnancy. It's been used very widely in pregnancy. So in general, it is recommended. I would just check the government advice specifically for pregnancy. And one of the questions there is, if I'm immune suppressed, should I be avoiding the vaccine? I would argue strongly otherwise. If you're immune suppressed, you should be avoiding coronavirus disease, and therefore you should be getting vaccinated. So, but just check the Ministry of Health website or ask lead maternity care for the advice around when in pregnancy it's reasonable to have it. I would ask that question. I don't see many patients who are pregnant because I'm mainly working in hematology. Lee asked a question about people with Waldenstrom's being tested for antibodies. That's a really, really good question. There are tests that can be used to check if people have got antibodies against coronavirus, the SARS-CoV-2 virus. And there are a number of trials that have taken people with blood cancers, have given the Pfizer vaccine or other coronavirus vaccines, and then looked to see if patients with blood cancers develop strong antibody responses. At the moment, as far as I'm aware, none of the laboratories in New Zealand are offering that test as a sort of district health board or funded test. It's quite possible that in the future we might be able to use antibody levels to guide whether people need additional boosters of the COVID-19 dose, and to guide whether it's safe for people to travel overseas to areas with high COVID-19 rates. At the moment, it's not something I'd be advising routinely. I can imagine if I was immune compromised and I was seriously considering, for very strong reasons, needing to go to an area with high COVID-19 disease, that I might want to privately pay for that test. But at the moment, we don't know how predictive the test is of whether you are going to get severe COVID-19 disease or not. So at the moment, it's not something we're able to recommend. It's not something I'm able to request from my patients. It may be that measuring antibody levels to guide vaccine responses might be used in the future. For people who are talking about having a stem cell transplant, splenectomy, this is from Heather, family members with contact with border workers, constantly hearing about the benefits, but troubled time to get the vaccine. So when are you going to get the vaccine? That's a huge question. And we were talking about that, Tim and I were talking about that earlier. And of course, that's the question on many people's lips. When am I going to get this? I don't have more information than you. So this government is seeking to be as consistent as they can in their messaging. And I think what they're trying to do is wait until they have enough doses. So patients with cancer, including blood cancers, are part of an enormous group of the population, a third of the New Zealand population, called Group 3, which is basically defined as people at increased risk of severe COVID-19. And that includes everybody over 75, everybody who's a rest home resident, and everybody with cancer, as well as a number of other groups. So this is a very large group of people. And I think behind the scenes, what's happening is the government is working hard to try and make sure they've actually got enough vaccine doses to hand to vaccinate those 1.7 million people. And the problem is that they are doubtless in competition with other countries throughout the world who are also scrabbling to get their hands on vaccine doses as quickly as possible. So I don't know exactly when you will be offered the vaccine, and I can't tell you that. It is being done health board by health board at the moment. We, as you, are being advised that people will be contacted when it's offered. I'm aware that some health boards are rolling it out sooner than others, and I just don't know when you as individuals will be offered that vaccine. The good news in this country, at least, is that we don't at the moment have community transmission. Therefore, your risk at the moment, even if you're severely immune compromised, should be low. So that's the good news. I would dearly love to know when you're going to get vaccinated, and I can't give you a firm guarantee around that. The latest I've heard, I think there was an announcement yesterday saying that it's going to be late May rather than early May. And again, it's probably around getting hold of enough vaccine doses and making sure everything's in place. What I anticipate is that people will be identified through GP records, which do include people's cancer diagnoses. I wouldn't be surprised if there are some border issues around certain disorders. An example might be myeloproliferative neoplasm. You know, is myelofibrosis a cancer or is it not? And I wouldn't be surprised if we have a little bit of scrabbling and might have to, as cancer centres, write the odd letter here or there to get people on certain lists. But until we actually see the mechanics of that rollout, I'm not able to say that right now. I would say that something I wanted to say earlier is that I would argue that people with blood cancers are among the highest risk groups of getting severe COVID-19 disease, possibly even higher than people, for example, on dialysis. And for those of you who are actively on treatments that are going to compromise your ability to respond to the vaccine, herd immunity is critical. And I'd like to hope that many patients with blood cancers and LBC itself are among the strongest advocates for everybody to be getting vaccinated. It's absolutely critical. And I'm saying this to people within our department, that it's not just patients, but it's your family, your friends, your colleagues, your healthcare workers. We really need people to get vaccinated, because people like, well, I'm at moderate risk because I'm male and I'm in my late 40s now, but people like me are not at necessarily at huge risk, but we need to get vaccinated to prevent people like you getting severely ill. And this is absolutely critical. And I feel very passionately about this quite personally. Does polycythemia vera put you at high risk of blood clots? So no, it doesn't put you at high risk of blood clots from the Pfizer vaccine, because there is no increased risk of blood clots above the background risk for the Pfizer vaccine. There are some questions, and you'll see some things from Australia and the UK where they're rolling out a COVID-19 vaccine by AstraZeneca. That does not apply to the Pfizer vaccine. If the AstraZeneca vaccine is rolled out in New Zealand in the future, and it might be, then we'll be providing messaging and contributing to the government about recommendations about that. But for the Pfizer vaccine, no, history of polycythemia vera does not put you at increased risk of blood clots, and you should go ahead and get the Pfizer vaccine, in my view. Can you have the Pfizer vaccine if you're on prednisone 20 milligrams daily? Yes, you can. Your response to it might be diminished because the prednisone might suppress your immune response, but you can safely receive it. Now, depending on what you're taking the prednisone for, there may be the possibility of the dose being weaned a little bit before you get vaccinated. Don't do that on your own. You may be on that dose may have been reached for a very critical reason for you. But for a few patients I've had where we've been considering weaning the dose anyway, I've started weaning the prednisone dose a little bit before people get their COVID vaccine doses. But that would have to be done in consultation with your clinician. But yes, you can have it. Antibody-dependent enhancement, no, there's not been any evidence of antibody-dependent enhancement. So there's a particular phenomenon that's happened with a handful of investigational vaccines. One example was a childhood vaccine for rotavirus about a decade ago, where there's a theoretical concern that some vaccines could increase the chance of getting severe disease. That has not been an issue with the Pfizer or Moderna COVID vaccines, and the degree of protection from severe COVID-19 disease is enormous. Again, in the real life data from Israel is 95% protection against hospitalization, 95% protection against getting severe symptoms, 95% protection against getting any symptoms. So there is no systematic concern about antibody-dependent enhancement with the Pfizer vaccine at all. Am I worried about PEG? No. So every vaccine, every drug you take, in fact, every medicine you take has an active ingredient and it has something called excipients. The excipients are the other things you put in that medicine to make it work, to make it stable and to make it so that you can give it. So for example, if you're taking a tablet, that tablet is not 100% the drug that you're taking. There's also other constituents. It might be a capsule. It might be the stuff, the powder they need to do to make the capsule hold together or to give it particular properties so that your body absorbs it. In the case of a vaccine, they have to put things in, and intravenous medicines as well, have to put things in to stabilize it and make sure that it's safe to give. So there's a very, very low rate. It's less than 1 in 10,000 of allergic type reactions to the Pfizer vaccine, as there can be to any vaccine. In fact, we see a similar rate with flu vaccines. For that reason, all the vaccine administrators are trained in that, and all the centers that are giving the Pfizer vaccine, whether they're in hospital or whether they're outside of hospital, have sort of emergency kits in case someone gets an allergic reaction. That risk is extremely low. One contraindication, I mentioned this, one reason not to have the Pfizer COVID vaccine is if you're known to have an allergy against some of the components of the vaccine. This would be very rare indeed, and many such people will have probably seen immunologists in the past to assess for those types of allergy. Having a history of hay fever, gluten intolerance, all those sort of things, they are no issue with the Pfizer vaccine. And it shouldn't be an issue that there might be similar excipients to something you're taking in tablet form. From auto-transplant myeloma patients, can I have the vaccine while on treatment? Yes, you can have in my view, in our center, we are saying people can have the vaccine on treatment. We're advising not to have it on the actual day of chemotherapy, but on other days. And for autograft, we're recommending people wait for 3 months after the autologous transplant before having the vaccine. Not necessarily an absolute, but that's what we're suggesting. If the virus is so small and can only be seen with a microscope, how can a mask keep it out? What a great question. And that's very true. And that's because the mask is not thin enough to prevent the virus itself getting through, but the virus, when it's floating around in an aerosol or when somebody sneezes it out, is not floating free in the air, but it's within a little droplet. So what the masks are doing is preventing you inhaling the droplets or the aerosols, and those are many, many times larger than the virus particle itself. So even one droplet from a sneeze from someone with this might contain millions or maybe even billions of virus particles. Does the vaccine protect against all the variants? I've mentioned that, yes, most of the variants it responds very well. Are you more likely to get a better response to the COVID vaccine after a second dose if you're not making antibodies after the first dose? That's a good question. So this concept of what we call boosting by giving a second dose of a vaccine is very, very, very well established. It's been used for vaccines for eons. You might notice if you look at the childhood immunization schedule that several of the vaccines are given numerous times during childhood to boost the response and protect as many people as possible. That is important for the Pfizer COVID vaccine. It's particularly important in patients with blood cancer. It may be that patients with blood cancer need to have additional boosters above just the 2, and we're only going to discover this through ongoing trials and retrospective studies that are being conducted throughout the world at the moment. But you should still have both doses. Even if you don't respond well to the first, the second might be enough to give you a bit of protection. And just to point out, it's not necessarily that last 10% of protection you're aiming for. It's that first bit. If you're a blood cancer patient, it's that first bit of protection that might make all the difference between you getting a flu-like illness from if you catch COVID-19 compared to being intubated and ventilated on an intensive care unit. So even that small amount of protection could be critical for you. Therefore, even if you're currently on chemotherapy, even if your chance of getting the full vaccine response may be diminished, even a bit of protection, I would argue, is critical for you, and I would still be advocating you get the vaccine. If I'm having rituximab maintenance, it's safe to be vaccinated. Yes, it is safe to be vaccinated. Again, unfortunately, the rituximab maintenance that you're on is likely to diminish your protection, at least in antibody terms, from the vaccine, but you can receive it. I just recommend not having it on the day of treatment. I mean, the reality is that rituximab hangs around in your circulation for probably a good 3 months. So when would you time it anyway? I'd just get on and have it, because you may still develop some so-called T-cell response to the vaccine that might be protective, and that might be sufficient to prevent the worst manifestations. But it may be that later on, in a few years' time, when you've finished rituximab maintenance, you might need additional boosters. There's a question about 6 months. So the rituximab effect on the B cells and antibody responses that's true, lasts at least 6 months. And in fact, there's some data that the response are diminished for a good 12 months after rituximab. Doesn't mean you shouldn't have the vaccine, because you can still have T-cell responses to the vaccine, which may be enough to prevent the most severe manifestations of COVID-19. And personally, as a clinician, if I was advising someone to avoid COVID-19 vaccine and then they caught it and got sick, I'd recommended that they had it. Even if they got some protection, at least we'd know it was in. A family member believes this vaccine is sinister. So, and we've been watching YouTube. There is a lot of vaccine misinformation out there. And it seems to be, to me, anecdotally, to be very regional. I've noticed a big difference in what parts of at least our region people are from. And I think there's a lot of bizarre, uninformed misinformation about this and a number of other vaccines, in fact, going on out there. It is not sinister. I'll tell you what's sinister is COVID-19 disease. I think we're so privileged to have been sitting out this pandemic in a country like New Zealand. I trained, as you probably know from my accent, I trained in the UK. I've got many friends who are working in the UK. I can tell you that in the UK, at the hospital I trained at, haematology consultants, haematology registrars have been pulled out of clinics looking after patients like you, and have been doing nursing support shifts in intensive care units because there's not enough people to just manage all the ventilated patients. They've been taken away from blood cancer patient care in order to turn patients over in intensive care units. My own hospital that I trained at started out with 1 intensive care unit. They had to open intensive care unit 6 at the peak in the UK because they just didn't have enough beds to ventilate all the patients. We had in the UK, in some centres, saw a 30% mortality rate among people with haematologic cancers, blood cancers, who got COVID-19 disease because they were overwhelmed and they couldn't cope. They didn't have enough ventilators. And the situation in the UK, many people would say, is a lot worse than was publicly outlined by the government. You only have to look at India right now to see what this does. It's the virus that is sinister, not the vaccine. You can't necessarily change the mind of everybody that you speak to, but I would combat that at every stage. And it's people like, it's all of us, but particularly people with blood cancers who really need this vaccine uptake to be high in New Zealand, so that we don't suffer the kind of disasters that were seen in the north of Italy, in the UK, currently in India and Nepal. We need to avoid these disasters coming here. And the only way, and I would regard at this point in time, the only ethical way to get herd immunity and avoid a country becoming overwhelmed once borders reopen is going to be vaccination. What is a good neutrophil count to help the response to the vaccine? So actually, you don't necessarily need neutrophils to make vaccine responses, but severe neutropenia is probably a reflection of the fact that you've recently had chemotherapy, and that many of your other immune cells might also be at least transiently damaged by that chemotherapy. But if, for example, you had long-going severe neutropenia because of autoimmune conditions, I would just go on and get the vaccine anyway. There are a couple of things I would note. One of them is I don't particularly recommend getting the vaccine intramuscularly if your platelet count is currently below 30. Sometimes for people with very low platelets where it never comes up, we might be advising the vaccine is given subcutaneously, which is an injection just beneath the skin. We do that with other vaccines. The other thing is if you're currently taking the blood thinner called warfarin, which not many people are these days, but a few of you might be, we recommend the INR is less than 4 on the day of vaccination, and that you press for longer, because people can get a big bruise or lump at the injection site if your INR is very high. If you're currently taking the other blood thinners like rivaroxaban or dabigatran, no issue, just go ahead and get the vaccine. Where's the data on BTK inhibitors versus rituximab patients? There was a study looking at chronic lymphocytic leukemia published in Blood that gave some information about responses in people on BTK inhibitors and rituximab. I'm not aware of data specific to BTK inhibitors used for other conditions like lymphomas and Waldenstrom's at this point, but there is a paper from, I think, December from the United States looking at vaccine responses in people with CLL, published in the journal called Blood. And there's a lot more of this information emerging as we go forwards. Nonetheless, even if you're on those drugs, I still recommend vaccination. Lots of questions coming in. This is good. Why do I have to call Healthline to find out that I am eligible? I didn't personally say I think you'd necessarily have to call Healthline. That might be what the that might be what's recommended. So the issue specifically here is that the guidance that the government has given around at-risk groups is very broad. We have been told, and it says on the government website, that they will be looking at other individual groups. At the moment, it just puts people with cancer in group 3 and is relying on health boards and primary care records to recognize what constitutes people with cancer. So there are a number of hematologic malignancies that may or may not be defined as cancer depending on what you're trying to achieve. And examples of those, well, they could include myeloma because it hasn't got the word cancer in the word, in the description of the condition. Similarly, things like Waldenstrom's. I'd be very firmly arguing that those do constitute a cancer. They are a malignancy. And if we do start to find that people with blood cancers that don't have cancer in the name of the condition aren't being recognized, we'll have to ensure that the government puts these conditions in the at-risk group. Again, I'm as in the dark as you are because the government's staying quite tight-lipped about these criteria, presumably because they want to announce everything in a flash. I do believe that the CACART, which is the Cancer Control Agency's advisory group for COVID-19, is aware of this issue. And then again, there may be some other conditions where it's a bit more nuanced. Is myelodysplasia a cancer or is it a pre-cancer? These issues won't be specific to blood cancers. They'll affect a number of the other malignancies as well. The only exception made from the word cancer, I think, is localized skin cancers. That's specifically excluded in the Ministry of Health website, but they don't, for example, specify any exclusions around, say, polycythemia vera, which I wouldn't normally refer to as a cancer, but if it meant you got the COVID vaccine sooner, I would. Are people unable to build up antibodies to the flu vaccine likely to build up enough antibodies to prevent a serious COVID event? Someone with low IgG and low IgA lymphocytes? I don't know. You're right that people with profound immune suppression, which includes due to conditions like CLL, myeloma, lymphoma, are known to have a reduced response to vaccines against influenza and pneumonia. And it's quite likely the response to COVID-19 vaccines will be diminished. Having said that, again, just to emphasize, some immune response is better than none, and I suspect many of you will develop at least some immune response and therefore should be vaccinated. Again, we've seen data, so just to put it into perspective, in myeloma, for example, there have been studies suggesting that 2 doses of the flu vaccine each year or double dose of the flu vaccine can overcome the reduced response. It's likely that quite likely even before New Zealand's borders open more widely, we will have published information like this from centres like the in Europe and the US, where they're going through this before us, where we can learn from that information and hopefully apply it. Do we have the same type of vaccine for a second dose? At the moment, I think so, yes. I think the intent in New Zealand will be to give each person both doses of the vaccine on time within 3 weeks. I think that's the intent in New Zealand. Some countries, they decided to defer the second dose. That was because they had active high levels of community transmission. So in the UK, they did that. I believe they might be doing so in Sweden. But in New Zealand, it's not... because we don't have widespread community transmission, I think it'll be about getting the best response to vaccination from each person rather than trying to very rapidly control an outbreak. Now, of course, that could change, and it could change on a dime, and we'll be watching that the same way as you. Well, look, I've answered a lot of questions, and hopefully that's answered many of them. I wonder if, Tim, you want to say anything? Chris says, can there be a partial response to the vaccine or all or nothing? No, absolutely, there can be a partial response. And again, just to emphasize, some protection is better than none. You can definitely have partial responses. And does being further away from transplant help? Yes, it does. But there's data for flu and pneumonia vaccines that you can get some responses within about 3 months after transplantation. So yes, being further away helps, but I would tend to favor getting a vaccine jab as soon as you can, if you're at least 3 months out. And then if it looks like you might need boosters, that there may still be the time allowed for boosters before we have widespread opening of the New Zealand borders. But yeah, thank you very much, everyone. I'll just hand it back to you, Tim. Thank you.
Awesome. Thanks, Rob, for your time, and really appreciate you taking the time out to answer all these questions. I think we counted probably 30 questions all up that you answered in our time that we've had. So that's pretty cool. If there are any other questions, we'll take them down and we'll get them answered a little bit later. And we can send a message out to you guys. Just on what Rob said about vaccinations, I just wanted to share that many of us here at LBC have had our vaccinations done as well. Some have done both jabs, other people have done one, and we're waiting for the rest of the organization to be vaccinated as well.
And it's fine, guys. You know, a slightly achy arm after the second one, and I felt went to bed early after the second day. But look, I think there's a silly deal being made of this in some quarters, and I think people just need to harden up and get vaccinated, because we're doing this for everybody. We're doing this for the whole country, not just people with blood cancers, but people with diabetes, kidney transplant recipients. You know, this has got to be a national thing, and I hope that you can encourage those around you and just try and educate people that, you know, that they're doing this. They need to do this for you and for everybody else. Yeah, we've got a lot of vulnerable populations out there. We need to protect everyone.
Really appreciate that message, Rob, and we'll definitely be taking that out to our patients and arming them with the knowledge that we've learned today. Looking forward to helping you to have a good day today, and looking forward to the next time we catch up with Rob.
Yeah, and hopefully you get invited really soon. I wish I could tell you when it's going to be. I don't have any insight. The government's keeping very close-lipped on that one. Yeah.
Cool. All right. Thank you, Rob. Thanks everyone for tuning in. You guys have a wonderful day.
Thanks, guys. Have a great weekend. Thank you.